Yeah, so we used a large data set from Symphony Health that basically aggregates data across the US market with some small exceptions by NDC, by National Drug Code, so we could see exactly the quantities of inhalers dispensed um, by strength. And then we used the drug labels and other information about the actual inhalers to understand the propellant weights and um, other aspects to estimate the the CO2 equivalents for a given inhaler at the NDC level. So it goes beyond some prior analyses in terms of adding some increased specificity by doing it at the NDC level, which compares to some prior analyses which were focused at a higher level without taking into account strength. So the first thing is that there's just a lot more use of metered dose inhalers. So 70% of the inhalers prescribed during the study period were metered dose inhalers. And there are hard questions about why we have so much metered dose inhaler prescribing. There in other countries, the relative rates of metered dose inhaler prescribing is less in some other countries, which we could get into. But the first answer to your question is part of it is related to the use, and then part of it is just related to the the CO2 equivalents associated with metered dose inhalers. So because of the propellants, the hydrofluoroalkane propellants, a given metered dose inhaler has roughly 20 times the emissions of compared to dry powder or soft mist inhalers. So you take the fact that 70% of the utilization is from metered dose inhalers and the fact that they have greater emissions associated with a given inhaler gets you to 98% of the emissions being from metered dose inhalers. So, one thing to just note, just one caveat, is that we included inhalers that were approved for asthma or COPD, though we don't know why a given inhaler was prescribed, and often inhalers are prescribed off-label, especially albuterol inhalers. So just to be careful around the idea that while these were all inhalers approved for asthma and COPD, these could have been prescribed off-label, which we don't have insights into the why they're prescribed. In terms of notable trends, a couple of things kind of stand out. Overall, we've just seen growth in the use of inhalers, although we've also had population growth, and so that was expected. There's been a big growth really in the last year or two in use of generic inhalers and authorized generic inhalers compared to brand name products. At the start of the study period, almost everything was a brand name product, and by the end, I think it was something like just about a third were brand name products. So that was kind of a big finding. But in terms of at the product level or at the class level, therapeutic class level, it was fairly consistent trends in terms of dispensing patterns during the study period. The overwhelming majority of inhalers that are dispensed in the United States are short-acting beta agonists, and specifically albuterol, and that was true throughout the study period. One of the things that we were a bit surprised by was that we saw higher emissions intensity in the Medicaid population, meaning that in general, for a given inhaler prescribed in Medicaid, there were more emissions associated with that inhaler on average compared to Medicare commercial populations. And when we look further at the data, it seems to be related to the fact that there's just more metered dose inhaler prescribing in Medicaid, and specifically more short-acting beta agonist inhaler prescribing relative to other types of inhalers. So it just has us thinking about trying to understand that a little bit more and unpack that a little bit more. We know that Medicaid populations would be enriched for asthma, for patients with asthma, whereas Medicare populations would be more enriched for patients with COPD. And it's possible that we just are picking that up, that there's more albuterol prescribing because there's more asthma and because there's because the meter dose, because albuterol comes predominantly in meter dose inhalers, that we're just picking up that signal, but we're going to try to probe that a little bit further. I'm very glad you asked about physicians and health systems and policymakers, because I think what we don't want to do is place undue burden on physicians or patients who are often limited by formularies. So I think the bottom line is we want to make sure that patients have the therapies that they need in a form that's accessible, that's affordable, and ideally that doesn't cause as much harm to the environment as other products. So that being said, at a patient physician level, there are ways of trying to prescribe dry powder and soft mist inhalers when we can, when they're on formulary and patients can access them. I think at the level of the health system and at the level of policy, we want to do what we can to kind of incentivize dry powder and soft mist inhaler prescribing when appropriate. There are certainly times when meter dose inhalers are needed. So that's number one. Number two, there is one product that exists as a dry powder inhaler, budesonide formoterol, in other countries, including European countries, but not in the US. And because of the way asthma treatment guidelines have changed, I think it would be a big win if we could get a dry powder version of budesonide formoterol to the US market. And then the third thing is that we have inhalers coming that have novel propellants with low global warming potential, very promising. I'm glad that companies are developing those. They have a fraction of the emissions compared to current meter dose inhalers. So I think promoting those, but policymakers need to remember that the last transition that we had from chlorofluorocarbons to hydrofluoroalkanes, there was a big jump in prices and patient out-of-pocket costs went up. So we have to make sure that in this next transition that we preserve patient access, that we don't see price hikes that limit options for patients. And I'm worried about that. So I think we have to be very careful moving forward.